Today we have Dr. Mark Stein. He is the director for the Pearl Clinic, and ADHD and Related Disorders Program at Seattle Children's Hospital, and an investigator at Seattle Children's Research Institute. He is also a professor of psychiatry and behavioral science and a professor of pediatrics at the University of Washington. And Dr. Stein currently serves as the president of the American Professional Society of ADHD and Related Disorders. So please welcome Dr. Stein.
Thank you so much for the introduction, and it's a pleasure to talk to you this afternoon. Let me get slides up. So I guess I should start with my disclosures. I consult for several companies, but I won't be talking about anything related to any of those today. I'm going to talk to you about three disorders or classes of disorders that are especially common in children, especially ADHD and learning disorders, and to a lesser extent OCD, and try to describe their clinical characteristics, how we measure them, common treatments, and things to look out for with the perspective of during COVID, resources are strained. It's so hard to make referrals. And so I think identifying the right program, the right intervention for the right patient profile is, especially important. So let's start. We're going to start by talking about ADHD. And ADHD is attention deficit hyperactivity disorder. And it's one of the most common childhood psychiatric disorders. And the prevalence seems to be increasing every year. We say that about 10% of children, up to 10% of children may have ADHD, about 6% of adolescents, and about 4% of adults. And the group that actually is least likely to be treated are adults with ADHD. It's a disorder that in childhood presents more in males, or males are identified sooner or earlier. But by adolescence, the gender ratio is even in terms of males and females. When we talk about ADHD, we talk about three subtypes or three different formulations. There is the combined presentation, which is the type that we see most often in clinics. And these are children that have both inattention and hyperactivity. Then there's another subtype for children that are predominantly inattentive. And there's another subtype that is pretty rare, that are children that are hyperactive and not inattentive. And that really is meant to refer to kindergartners or preschoolers who are hyperactive and they really haven't had the opportunity to display inattention. So the most common presentations are the combined and the inattentive type. An important thing to remember, besides how common it is that ADHD is a disorder that often persists. Even if all the symptoms don't persist, sometimes the impairment does. But about 60% of the time, if you take a child with ADHD, they're still going to have it as a young adult, which I guess means 40% of the time they don't have it. But you should expect people with ADHD to have continuing difficulties. And that's really important for treatment. It's not a disorder. It's not like, an infectious disease, for example, that you treat one course of medication and you're done. It's more of a chronic illness, and the symptoms and impairments vary over time. It's not a new disorder, although many times you'll talk to a parent and they'll say, well, when I was a child, no one talked about ADHD. But it's been around for quite a while. I'd like to show this slide. This is Heinrich Hoffmann, who is a physician in Germany, who wrote a children's book, and he described this character called Fidgety Phil. He's the little guy in the red there. And Fidgety Phil couldn't sit still, and he falls off the chair. And one of the characteristics, you notice his parents are these stern-looking mother and father. But it kind of reflects how difficult it is to have a child with ADHD. And we see high rates of depression and high rates of ADHD in parents of kids with ADHD. And then this is what happens next. He pulls off the tablecloth at dinner. lots of kids with ADHD combined type really struggle sitting down at mealtime. And many times they have motor coordination problems like this guy does. So what is ADHD? Well, it's a disorder, and it's characterized by two main symptom clusters: inattention and hyperactivity. And these are the symptom clusters. And when you look at them, what's troubling is that everybody has these symptoms from time to time. Some of us more than others. But the key is that ADHD means you have these symptoms and they're developmentally inappropriate, meaning that it's not what you'd expect based on their age. And it results in some impairment, which we're going to talk about in a minute. So all 3 or 4-year-olds have ADHD, or they have these symptoms, but we don't diagnose typically ADHD in 3 to 4-year-olds. It's when the symptoms continue and they cause difficulties. Kind of a layman's definition of ADHD might be the terrible twos continued. So you have a child that had these outbursts and inattention and was hyperactive, but now they're 5 or 6, and it's obvious at school that they're having these difficulties. So the criteria for the diagnosis is that you have at least 6 of these in either list if you're a child. If you're an adult, I think it's 5 right now. It keeps changing. But so these are the symptoms of ADHD. I want to mention sleep problems because even though they're not currently listed as a symptom of ADHD, there's such an overlap between ADHD and sleep. And I think it's important to think about them as mutually exacerbating conditions. So many people have both, and it makes your treatment a little bit more complex. And I'm an advocate of thinking about ADHD as a 24-hour disorder. We used to think of ADHD as a school disorder. And it's true, school is a toxic place for kids with ADHD. But we don't want to sacrifice days for nights. And certainly decreased sleep, variable sleep, makes you more at risk to have inattention, learning problems, mood problems, and learning problems the next day. So we really take it like a 24-hour view when we're evaluating someone for ADHD. And we want to screen for primary sleep disorders, as well as sleep problems that are associated with ADHD, especially problems like delayed sleep onset, decreased sleep, night-to-night variability, or circadian disturbance. And then a new sleep disorder called restless sleep. By the way, in previous diagnostic versions of ADHD, restless sleep was one of the criteria. Seriously got dropped, but I think it's something clinically you see very often. I think it should be part of all assessments. So why is it important to study ADHD, and what makes it seem like a syndrome? Well, the strongest evidence comes from longitudinal studies that take children with ADHD and follows them up into adulthood. And what that shows is that kids with ADHD are at risk to have lots of negative outcomes. If you think about school, they're at risk to do poorly in school, to fail more subjects, to do poorly on tests. And as a result, people with ADHD have more difficulties finding jobs and keeping jobs. As adults, they tend to have an unemployment history that's worse. They're earning less earning power. So there's the learning and occupational deficits. And then when you think about the consequences of impulsivity, children with ADHD as adolescents or adults are more likely to develop a sexually transmitted disease. They're more likely to have marital difficulties, to have relationship difficulties, to have unplanned pregnancies. And then more recently, we've learned a lot about the medical complications of ADHD. Especially cardiovascular risk factors, smoking, alcohol-related disorders. That's kind of the natural course of untreated ADHD. This is a study that Russell Barkley, who's a psychologist, did. where he looked at this sample of children with ADHD from Milwaukee and looked at them as adults and used a formula to predict their life expectancy. And he found that those with ADHD had a significantly lower life expectancy compared to people without ADHD. So no matter what setting you're in, ADHD has implications, especially if it's not treated. So when we think about a psychiatric disorder, we tend to think of like the worst case scenario. So as I'm describing ADHD and showing the symptoms, you're probably imagining like a 7-year-old boy that is hyperactive, trouble in school, trouble at home, has no friends, and parents are really frustrated. And that's the type of ADHD that is probably the easiest to identify. But there are other people that have milder versions of ADHD that are more common and more subtle and that may be missed. And I'd like to describe this case just to illustrate that. So this is a adolescent, we'll call her Melinda. I saw her, she was a senior at a private school, and she had no history of behavior problems. In fact, she was inattentive, kind of a model student. Teachers love having a student like this because, you know, no problems and no drama. But around middle school, her grades started to decline, and she developed headaches and tension headaches. And now she's in high school, and she's not sure what to do, what's going to happen after high school. Her teacher said that, you know, she had academic apathy. She had friends. She was doing well socially. She didn't display behavior problems at home. She studied, but she really had trouble completing her work, turning it in with organizational aspects. And so as a last resort, her pediatrician referred her to us for evaluation, and we were a little bit puzzled by her course and history. And so this is a case that psychological testing we thought would be helpful to kind of understand what her strengths and weaknesses were. So this is a summary of the testing that was done. She was given an IQ test called the WAIS, the Wechsler Adult Intelligence Scale, and the average is 100. And you can see she's a bright young woman. Her verbal IQ was 118, but her nonverbal IQ was a little bit lower. And what stood out is her processing speed. There's a test on the IQ test where you have to kind of copy marks quickly. And she was just slow on that. But everything else was fine. And so based on the reports of inattentive symptoms and the psychological testing, we recommended two things. We recommended accommodations at school, like giving her extra time because of the processing speed weakness. And we recommended a medication trial with a long-acting stimulant. And right away, there was a marked change in her motivation, her performance in school, and you know, her grades went from C's to A's. And all of a sudden, you know, she's interested in more colleges. She also got a writing tutor that helped her with her college applications. But it's just an example of how ADHD can be missed, but it comes again, and you don't miss an opportunity to treat it, and it really makes a significant difference in her life. An anecdote is after people heard about and saw the change in her, we received about 10 referrals from her classmates, but none of them had ADHD. So let me just talk about how we evaluate or diagnose someone for ADHD. And I understand that you're all in different settings, and it doesn't matter if you're in a specialty clinic or primary care. I think when you evaluate someone for ADHD, you want to have the same approach in terms of looking for 5 main areas. Number one, do they have symptoms, which we already talked about, the hyperactivity symptoms and the inattention symptoms, or either or. And then secondly, there needs to be some impairment. Can't have symptoms without impairment. It has to be affecting your function. The main part of an evaluation is to rule out mimics or things besides ADHD that cause those symptoms. And we think about medical mimics, things like thyroid disease or seizures or not hearing or not seeing. And then we think of psychiatric mimics, like having another disorder that accounts for the attention problems, like depression, for example, but almost all psychiatric disorders affect attention. So that's kind of tricky. And then there are also social factors that can mimic ADHD and social factors that can cover it up. So it's important to tease those apart. The fourth thing to evaluate is what we call comorbid conditions or other things that come with it. It's rare to see someone that has just ADHD or ADHD simplex. About 70% of the time it comes with another problem. In children, it's usually a learning or behavior problem. In adolescents, it's usually a learning, a behavior, or an emotional problem. And then in late adolescence and adulthood, you have to consider all the disorders that start in adulthood. And so it becomes a little bit more difficult. So we don't worry about substance abuse or bipolar disorder in children. But in adolescents or adults with ADHD, you have to consider those factors. And lastly, you want to assess what are their strengths or what are their protective factors. So we have really good treatments for ADHD, but the treatments mainly address the symptoms, and the treatments all wear off. So that's why it's important to identify what their strengths are, and a good treatment plan identifies their strengths and builds those up. So if someone has ADHD, for example, and they're a good athlete, or they have good social factors, or they're good in math, that should be part of the treatment plan. And then in terms of implementing treatment, it's always important to assess the family. Who in the family has ADHD or another psychiatric disorder, and is it treated? Because if they're not treated, that's going to impact the child's treatment. So impairment is just really key. And impairment is what differentiates ADHD, treating ADHD from just performance enhancement. So in children, impairment usually means problems at school, problems at home, problems in self-esteem. In adults, it usually means problems in work, problems in their relationships, or problems in self-esteem or friends. And what we look for is having a pattern of impairment that's related to ADHD. This may be the reason they're seeking treatment. They might not realize that it's ADHD, but they might say, I'm not learning, or I'm struggling with relationships, or anger control, or emotion regulation, not understanding that comes from the ADHD symptoms that are not treated. So our goal in treatment is always to minimize impairment and improve functioning. So just to give you some tools to kind of screen for ADHD or to assess it, I'm a big fan of rating scales, especially to screen for ADHD and to track treatment outcomes. So probably the most commonly used now is the Vanderbilt scales. And what's nice about them is they're free, and either a parent or a teacher can complete them. And it doesn't take too long. And then you get a sense of how they're doing in multiple settings. So you want them to have a significant number of ADHD symptoms that are often or very often. And then those are your targets for treatment. And you keep increasing the intensity of treatment until those symptoms are normalized. Some other scales, the Conners scales, have a long history in ADHD. They have very good norms, but you have to pay for those. There are other scales that assess a broader range of problems, like the Achenbach Child Behavior Checklist or the BASC. So impairment we usually assess just by interview, but there are some scales, and this is one of my favorite scales. It's called the Weiss Functional Impairment Rating Scale. And there's two versions. There's a self-report version for adolescents and adults, and there's a parent report version for parents. And this just asks the informant to check off what are the areas of impairment, and are they often or very much. And you can quickly see where the impairment is. Is it home? Is it school? Is it risk behavior? Or is it life skills? And then target their treatment. So if the impairment is home and not at school, you're probably not going to recommend an ADHD medication for school. If it's school though and not home, that might be a different issue. And you have to figure out what's the discrepancy. Why are they not having those problems at home or in peers? Some of the most challenging patients to diagnose are adolescents. And I'd like to think of adolescents as kind of two types, similar to how we think of diabetes. So type 1 is someone with ADHD that's an adolescent that had it when they were a child and they still do. So that's the easy one in terms of diagnosis. You know what their diagnosis is. They might have some new problems because they're now a teenager. I should mention, though, that many children with ADHD actually do better in middle school. The opportunity to change classes and to move around a little bit more, many of them really adapt well to that, even though they fear it. So it doesn't necessarily get worse in middle school. But one of the things that happens around age 12 or 13 is they become teenagers, I guess 13. And part of that is kind of the belief that there's nothing wrong with you. And so if the ADHD had been treated with the parent giving the child the medicine and not really engaging the adolescent in why they were taking the medicine, what often happens is that the adolescents might decide they don't want to take it. Or there might be something about the medicine that they don't like. Might be impacting their growth, for example, or impacting their sleep. Or they might feel that their personality is different. So those are reasons that adolescents often discontinue medication. And it's really not good because many of them have ADHD symptoms. And because their impulsivity as adolescents, they can even get in more serious trouble. Think about, teenage drivers, for example. So our treatment needs to shift from being through the parent to really treating the adolescent as a partner. And the focus needs to be on adherence and engagement. So this is a shift. But these are the relatively easier ones, the kids with ADHD that are now teenagers, which is about 60% of them. The second group are the type 2 adolescents. I call these the kind of hitting the wall ones. So sometimes you have really bright children with ADHD who get by on their IQ until middle school. And then all of a sudden they're responsible for things and they start to, their problems become more significant. Sometimes they have helicopter parents that make sure they do their homework, but they're not able to do it as well when they get to middle school. And there are other factors like environmental factors, like a child that the parents move a lot or shift schools, so no one really gets a good assessment of what their learning is like. We have what I call red herrings, which are children with ADHD, but they go into the wrong door or see the wrong provider who identifies the wrong problem. So someone might say, okay, you might not be doing well at school, but that's because you have these traumas in your life. Or that's because your parents expose you to alcohol or methamphetamine. Those may be true. Kids with ADHD have parents that do all those things and are exposed to trauma. But that does not mean you do not have ADHD or will not respond to ADHD treatment. And delaying their diagnosis and treatment only hurts these guys because then they just fall farther behind. Then the third reason is someone that has another problem that is more significant, like a child with significant conduct problems, or someone with major depression, or someone that has a traumatic brain injury. So again, the type 2s are more complicated. Now, I think that one of the questions you might be asking yourself is, how often should ADHD be identified or treated in primary care versus how often should it be treated in the community? I mean, by a subspecialist. Probably about 80% of the time it should be treated in primary care. And maybe 20% of the time is when you want a subspecialist, either because the ADHD is really unclear, like the case I presented, or someone with type 2 ADHD, or because there's a lot of medical or psychiatric comorbidity, depending on the setting you're in. You might want to refer those, although now during post-COVID, it's very, very challenging to refer anybody. So we have a clinic at Children's, the Pearl Clinic, that's meant to be a resource for primary care to refer complex cases. And what we do is we use this program called Inside Out Care to help families navigate the evaluation. So before they come into clinic, they fill out forms about their medical history and family history and get parent and teacher rating scales and measures of impairment, so we have all that information as well as previous evaluations, and that way we can be a little bit more efficient when we see them for evaluation. So now I'm going to switch and talk about treatment. We did talk about diagnosis, and I think treatment really begins with diagnosis. When you do an evaluation with symptoms, impairment, mimics, comorbidities, and strengths, the first step of treatment is letting the family and the patient, depending on their age, in a way that they can understand it, that they have ADHD and what else. And then it's an opportunity for psychoeducation in terms of what treatments are effective and what's recommended. So in the United States, we have guidelines. Both the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry have guidelines, and they're kind of based on age and severity. So in children under 6, we like to recommend behavioral treatment first, except for the severe cases. Severe means their ADHD is going to really put them in danger. And in those cases, we do recommend medication. And typically it's a methylphenidate stimulant, although increasingly people are using alpha-2 agonists for hyperactive preschoolers. In children 6 to 18, it kind of depends on the severity. For mild ADHD, usually behavioral interventions like parent training or teacher training or a 504 plan, which is a school accommodation plan, is recommended. But when you have moderately severe ADHD, medication is recommended with an FDA-approved medication. Here's a list of behavioral interventions. And not all behavioral interventions are equal. The behavioral parent trainings are the ones that have the most evidence behind them. There's very few treatments that are done with the child that have demonstrated efficacy. And so again, those are things that may not be harmful. The child may enjoy them, but they're not going to really have an impact on core ADHD symptoms. There are things like neurofeedback, which really have a mixed view in terms of their efficacy. Social skills training is something that's widely advocated. It also has not shown huge benefit in group settings, but there may be some individuals who respond to that. And increasingly, we're starting to have digital interventions. There are some medical devices. There's one called Endeavor, for example, that's cleared by the FDA for treatment. They all have limitations, which we can, if we have time, we can talk about that. But first-line treatment is usually a behavioral intervention, parent training, behavioral reward program at school. Something called a daily report card is something that's very, very effective, not too hard to implement. At Children's, we have a stepped care model that we start with low-intensity parent training. We have something called super parenting, and then we have a more intensive program called Incredible Years, which is reserved for children that have ADHD and aggression or who don't respond to the low-intensity program. And then we also have a psychoeducation program called ADHD First Steps that just helps parents learn about ADHD. So medications, let's talk about medications. So medications are commonly used. About 60% of children and adolescents with ADHD are treated with medication at some time. The medications have been used for over 70 years. The stimulant medications were first developed in the 40s. When we think about medications, we think about 3 types of ADHD medicines. There's the methylphenidate stimulants. Ritalin is the one that people remember. We don't recommend Ritalin too often anymore because it's an immediate release, short-acting stimulant. It has a duration of action of about 3 to 4 hours. So it necessitates taking multiple doses, which is really challenging for someone with ADHD. And some of the side effects related to ADHD medications occur when the medicine's wearing on and wearing off. And so you're more likely to have those with a short-acting stimulant. Then we have intermediate duration stimulants, which last about 8 hours. and then the longer acting stimulants that can last from 10 to 12 to 14 hours. So for methylphenidate, that would be Concerta or Focalin XR. And then on the other type of stimulants are the amphetamine stimulants. And the long-acting stimulants would be Vyvanse or Adderall XR or Dianavil or Mydayis. The short-acting stimulants would be Adderall or dextroamphetamine. And there are multiple formulations. There are liquid formulations, there's patches, lots of ways to take a stimulant medication. The efficacy of the stimulants is high, and at the group level, there's not much difference between methylphenidate and amphetamine. We'll talk more about that in a minute. Besides the stimulants, though, we have this class called non-stimulants. And there's two subgroups of the non-stimulants. There's medicines like Strattera or viloxazine, which are noradrenergic reuptake inhibitors. And they don't work directly on dopamine. They work on a slightly different neurotransmitter system. And their impact is more gradual. It's more subtle than the stimulants. And you have to take them a little bit longer. It's not like you see the effect an hour after you take them. So it may be a few weeks before you see the impact. But you also don't have the on-off effect that you do with the stimulant. And they have a different side effect profile. It's not like they don't have side effects, but it's different. Then there's a second class of stimulants, non-stimulants, which are the alpha-2 agonists. And that would be clonidine and guanfacine. And long-acting guanfacine is approved for ADHD either as monotherapy or in combination with the stimulant. And then there are a number of investigational drugs, and there are a number of drugs that are not approved for FDA approved that have been used. So there are many medicines to choose from. So what stimulants do is they help attention, they help productivity, and they really do a good job of treating core ADHD symptoms. It has a really large effect. And when you're on the right dose, you see the effect a half hour, 45 minutes after treatment. Stimulants also help with things like impulsive aggression, noncompliance, family interaction, teacher interaction, and handwriting. So those are things that you can kind of observe. What are the side effects or the adverse effects of stimulants? The main thing is that they can impact your appetite, especially when you first start a stimulant. Many of them were, like Adderall was first developed as an appetite drug, as a weight loss drug. The other most common side effect is on sleep. And stimulants tend to, at least at first, increase insomnia. And someone that has that to begin with, it might make it worse. Children with ADHD taking a stimulant take longer to fall asleep, but then they sleep longer and their sleep is deeper, typically. But there are less common side effects. Side effects like tics can occur, especially at higher doses. Cardiac effects in someone who's vulnerable to a cardiac problem. So that's why it's important to screen, do a good cardiac family history before starting a stimulant. And then in adolescents and college students, we worry about misuse and diversion. So it's really important to always monitor heart rate, blood pressure, and vital signs. Cardiac and growth are the things that we watch closely. And the important thing about stimulants is they need to be titrated to find the optimal dose. And then many times that changes as they get older or grow. So, understanding that the dose they're on now may be different as they get older. But you don't want to deprive a child of responding to the optimal dose. So we often recommend trying 2 or 3 doses during your titration to figure out what the right dose is to start. Non-stimulants are good for those that we are worried about sleep, or if you're worried about diversion, or someone that doesn't want to take a stimulant. So I guess just a few points to summarize about ADHD. You're going to see it no matter where you are. And you don't want to miss the mild ADHD, which is very treatable, because you can make a huge difference in someone's life by treating it. ADHD is very heterogeneous. goes from mild to severe, comes with lots of other problems. And the symptoms may be less obvious as they get older. So you want to pay more attention looking for impairment. What is the result of ADHD? And again, untreated ADHD is not a benign disorder. ADHD is highly heritable. A third of the time when you see a child with ADHD, you'll see another first-degree family member with ADHD. We have lots of treatments. The medications work very well in the short term, but it's important as children get older to modify medications and listen to the adolescent in terms of what their concerns are, and to make sure that they're engaged and on board in treatment. School is hard for people with ADHD, to put it mildly. And I always say if we can get someone through school, they have a decent chance, especially if they make it in the right career and they make good decisions in terms of their peer group. And we want to do all we can to help them succeed. So that using medicines, using behavioral interventions, and advocating for children with schools to make sure they're getting the appropriate services, whether that's with a 504 plan, where it's accommodations in the class, or whether it's an IEP, if a child needs extra help for a learning disorder or a speech problem. And again, most children with ADHD need more than one treatment. Viewing ADHD as a chronic illness, and they're going to need combinations of treatment over time that are going to change. So now we're going to talk about learning disorders, and that really fits from a discussion of ADHD because about 40% of children with ADHD have a learning disorder, and about 20% of the time it's a specific learning disorder. So what is the specific learning disorder? An example would be a learning disorder in reading or writing or math or developmental coordination disorder. And to diagnose these disorders, you'll get a hint of these from a history, but these really require testing, either by a psychologist or by the school psychologist or by an occupational therapist in the case of developmental coordination disorder. So to have a reading disorder or reading disability, a child should have an IQ test, something like the WFIRS, and a measure of reading. Similarly for writing, an individually administered writing test, or for math. Developmental coordination disorder refers to children that have problems with either gross or fine motor coordination that impact them. And think about the child with ADHD. We used to describe them as having neurological soft signs. They have difficulty in sports. They're struggling to ride a bike. Their handwriting is poor. And you want to diagnose them with developmental coordination disorder so they're not punished because of their motor coordination problem. And you want to advise the parents, maybe this child shouldn't play baseball, but they're a really good candidate for swimming or for martial arts or for something that doesn't put a premium on fine motor coordination. Another comorbid condition are communication disorders, which is a type of learning disorder. And about half of kids that have a speech and language disorder have ADHD. And you'll get this, many times they're referred first when they're 3 or 4 for speech, and then they're not evaluated again, and they kind of miss the ADHD part. But it might be a language disorder, or it might be an articulation disorder, or the child that just is socially awkward in terms of their communication. They don't have autism, but they have a pragmatic social communication disorder. And these are all things that are treatable once they're identified. Sadly, we do tend to see children that have intellectual disability, which are more global learning disorders that are missed, and many times misdiagnosed with ADHD. Yes, these children have attention problems, but they're not different from their performance in other areas. And so in a child that has developmental delays and learning problems, they should be evaluated. And they should be, what that means is they get an individually administered IQ test and a measure of adaptive functioning. And based on that and the clinical history, you can determine if they have intellectual disability, which is 1 to 3% of the population. And those with mild intellectual disability will need some support. Those with moderate will need limited support, and those with severe will need extensive support. But it's really sad when you see someone who's, beyond an age that there's much to do to help them, and they develop all these secondary problems because an intellectual disability was missed. The people with moderate and severe are less likely to be missed, and they're more likely to have either neurological or medical comorbid conditions. But there are many children with mild intellectual disability that are missed, especially if they don't have behavior problems. Okay, now we're going to talk about OCD a little bit, or obsessive compulsive disorder, which is a psychiatric disorder. And this is one that really requires a mental health professional to diagnose. But just to kind of review what it is, it's someone that has obsessions, meaning that they have recurrent and persistent thoughts, distressful images that are intrusive, that bother them, that kind of stick to their brain. That's not someone that loves baseball or someone that talks about Fortnite or what everybody else is doing. But typically they're disturbing, and they know they're disturbing. They know they're odd and unusual. And they have difficulty ignoring it or suppressing it, so they can't get on with their life because they're stuck with these distressing images or urges. And then that leads to compulsions, where they have to do behaviors like washing their hands repetitively or checking things, checking locks, counting things. And they feel driven to perform them, and they feel relieved when they do it short term, but it impacts them. And again, you have obsessions or compulsions, but there needs to be impairment. It needs to cause them difficulty in their life. So some ways to screen for OCD, I just listed some probes, and this will usually bring them out. So if you ask the child, do you have worries that won't go away, such as not being clean? Or do you have thoughts that upset you and you can't suppress them or get rid of them? Or there's some things that you have to do over and over again, even though it doesn't make sense. Those are kind of good probing questions. And then if they're positive, then you want to refer them for an evaluation where they use formal tools. There's one called the SciBox, for example, that can kind of quantify their symptoms are. So unlike ADHD, treatment for OCD is clinic-based. And cognitive behavioral treatment is first-line treatment, and that involves what we call exposures, exposure therapy. And there's pretty good efficacy data for CBT alone. It helps about 40% of people, but the best response is when CBT is combined with medication. And the placebo rate is relatively low. So again, there are active treatments, but it's work to treat OCD. So just some summary facts. OCD is 1 to 2% of children. The mean age of onset is between 9 and 10. And sometimes families really get involved in the obsessions and rituals, and you'll see all kinds of accommodations they make. And then again, when you see a family history of anxiety problems, that's when you want to inquire about OCD. And it often comes with other problems, tics, mood, anxiety symptoms, sometimes ADHD, but most of the time, the ADHD is secondary to the OCD or to the mood problem, and you treat that first. And you want to get information. It's essential to get information from both the parent and the child. And as I said, CBT is the treatment of choice. And the medicines that are used first line are the SSRI medications. So I've tried to kind of describe some common psychiatric disorders that you'll see, and that we really know quite a bit about how they present in their course and how to treat them. But if they're not evaluated or diagnosed, they're not going to be treated, and that's a huge problem. These disorders differ in their pathophysiology, and it's challenging to coordinate treatment, among providers. I just want to mention for ADHD, the treatments for ADHD are delivered by the parent. And so if the parent has ADHD, that's going to be challenging. So I think it's important to screen for ADHD in parents of children with ADHD. And one of the things we found is that many parents have difficulty getting treatment. And so because of that, we've been studying ADHD in parents. And so at Seattle Children's, we're doing a study called TPAC, which is treating parents and children for ADHD. And in this study, what we're doing is we're looking for parents that have ADHD symptoms that is not treated. So the parent is not taking ADHD medicine, but they might have ADHD. And if they have a child who's 3 to 8 who has ADHD symptoms, that's not treated. So we're looking for families like that. And if they're eligible, the families receive a free evaluation, and then they can receive treatment. And either treatment for the parent or treatment for the child as part of the study. Then we're doing another study. There's a new treatment of a medical device called trigeminal nerve stimulation. And we just started this study. And this is for 7 to 12-year-olds with ADHD who are not taking medicine, who might be interested in trying a new study. And the trigeminal nerve stimulation is looks like a Band-Aid that they wear at night. It's kind of like a TENS unit for the brain. And what they do is they wear this at night, and then they take it off in the morning. And this is a 4-week study where, again, people get an evaluation and they'll receive treatment. So if anybody has anybody that they're working with that might be interested in this study, please email me or my research team, and we'd be happy to tell you more about that and screen the families. So I think there's a little bit of time for questions. Sorry, I might have went over. But I guess the important thing is not to look away when you see symptoms of ADHD or learning problems or OCD, and to think about what are the probe questions and how to kind of get them on the right path. Thank you for your attention.
All right.
Take some questions.
Thank you, Dr. Stein. If you have questions for Dr. Stein, please put them in the chat and I can read them on your behalf. I do have some questions to kind of get us started. I think earlier you mentioned that most ADHD is managed 80% by primary care. So if you're seeing concerns in a child, would you bring them to a primary care office to get diagnosed, or would they need a special referral?
Yeah, it's a great question. I think that's the first step. Whenever you suspect ADHD, I think that the first step is to go to the primary care physician. So in the Pearl Clinic, we only accept patients that are referred by their primary care physician. And the reason we do that is ADHD is often a lifetime disorder. And it's really complicated in terms of coordinating all the different treatments and things that you need to do. And so there needs to be someone that kind of helps coordinate those things. And usually the pediatrician is the person that has the best view of the child. They know the family, they know the siblings, and they know the community. And their job is, first of all, to rule out the medical mimics, and then to guide the family for appropriate referrals. And then typically what they'll do is they'll also get like a rating scale, like a Vanderbilt, and then they should decide, is this ADHD that should be treated now, which probably 80% of the time it should be, but then what else is there and what other things are needed. And then the 20% of the time, again, because of lots of comorbidity or other concerns, what are the appropriate referrals? Should you go to a neurologist? Should you be seen by the Pearl Clinic? What would be most helpful, and they can help the families navigate that. But I think it's really important for kids to have a medical home and the parents not to feel like they have to do this on their own.
Mm-hmm. Thank you. There is a question in the chat. When you said a child's strengths like baseball should be incorporated into treatment, do you mean using baseball as an incentive for behavior? And can you explain that a little bit more?
Yeah. Well, I wouldn't think, I guess, so I'm just thinking of a patient I had that was like 16 who had really severe ADHD and reading disability, but was a great baseball player. And he was not getting the right services at school, and his grades were poor. And so he was not eligible to play high school sports because of his low GPA. And what we did is we got a 504 plan and changed his whole evaluation protocol and emphasized that he should be playing baseball. That's his key to self-esteem and to having positive peer relationships. So identifying the strengths and encouraging them. And sports are often really good for people with ADHD. And we do treat a lot of people with ADHD, for example, in Major League Baseball, Major Football. You're going to succeed if you do what you're good at. Sometimes ADHD gets in the way, but so that's what I meant in terms of the strengths. Now, using it as a reward, you use that, well, you want to think of what's rewarding to the patient and then incorporate that into a program to get them to do things that are hard for them. But you don't want to, like, for example, take them away from recess or take them away from things that they're really good at that are important. Otherwise, they're going to get depressed and angry at you.
Mm-hmm. A couple of questions regarding the studies that you mentioned, and the contact information for those studies. If you could put them in the chat. They are in your slides, so those are on our website, so we can also include the link for that as well. But if you don't mind just putting that in the chat right now. And then another question regarding naturopathic treatments that could treat ADHD.
There's been a lot of research on diet, and what it shows is that for most kids with ADHD, it has very little impact. And there's a subgroup of kids with food allergies that usually have other markers that are sensitive, but for the vast majority, it has very little impact. And then I'm not sure what the other treatments they were referring to besides diet, but.
Okay. And then I have a question regarding the goal or the goals of care for those with ADHD or learning disorders. Is that going to be specific to that child, that family, or is it, you have to take these meds and go through these treatments to perform at a certain standard?
Yeah. One of the things I like to do when I'm seeing a family for evaluation is I'll ask the parent, what are your top 3 problems, things you're concerned about? And then we also measure ADHD symptoms. And then if it's depending on the age of the child, like if they're older than 10, I'll ask them, what are you most concerned about? What are your goals? And then I think when you come up with a treatment, you want to try to address those things and try to make them be as consistent as possible.
Okay.
So you track symptoms, but you also track those problems, which really are typically related to impairment.
Mm-hmm. Yeah, I guess I'm wondering, how can we approach this from an anti-ableist lens for those who are neurodivergent, especially as they become adults and they go into the workforce. And you spoke a lot about the school system and 504s and IEPs, and I think those are not always followed, and school is used as a gatekeeping mechanism for people.
I'm sorry. So what's the question?
I'm curious, from your perspective, how can we approach this from like an anti-ableist lens? I'm only thinking about schools and those with learning disorders or ADHD struggle in school, and how can we better support them from your perspective?
Yeah, well, I think that's the treatment plan, is you identify what their symptoms are and their problems, and you treat their problems while you develop their strengths.
Mm-hmm.
I had a patient this morning that wants to go to college. She's a 17-year-old in high school, and she wants to go to college and become a psychologist, and yet she goes to an alternative school that's only like 3 hours a day. And she thought she had ADHD. I don't think that's really the problem, but I think she has a reading disability, and it's never been evaluated because somehow she's opted out of having to read. The school allows her to just do books on tape. So again, I think that we're kind of passing. We're not doing these children. We're not acting in their behalf if we're not helping them identify things that can be treated that we can help them with. So again, I think the goal should be, what are their strengths and how can we improve their function, and what are all the things we can do to do that?
Okay, thank you. A question or maybe a comment. I am familiar with a bright, articulate 3-year-old, but he repeats questions or requests even when he receives answers. Could this be a symptom of ADHD or OCD?
It could be a symptom of autism, actually. There's something called echolalia, which is when children kind of repeat things over again that they hear, or scripts. So I guess that's an important thing to have it evaluated. Probably a speech and language evaluation and running it by their pediatrician is what I would.
Thank you. And then what about differences in gender and symptoms related to gender, or any separation between gender?
Well, ADHD, we're more used to it in boys, and that's usually because it comes along with behavior problems that are kind of disruptive and in the teacher's face. So that's why they're more likely to be referred. And we miss it in girls who are more likely to have the inattentive type. So the peak age of referral for a boy with ADHD is usually 5 to 8. For a girl, it's more 10 to 12. And usually the girls with ADHD are referred because they're not learning or they have low self-esteem. But the reason they have low self-esteem or they're not learning is because of the ADHD. And I think, we've done a lot of research with mothers with ADHD that were missed, who have low self-esteem, are often diagnosed with depression, but it started with ADHD and they're really struggling and they're so treatable. So again, I think the symptoms differ by gender and by age and by severity. And the tip-offs are really looking at family history and looking at impairments that people have in different settings.
Okay. There's a question about gene testing to choose the right ADHD medication and treatment.
Yeah. So this is what's called pharmacogenetic testing. And this is an area actually that I do research in. Right now, there's really not evidence that there's a genetic test that can predict which medication you should try or if there are differences in dosing. For atomoxetine or Strattera, there are people that are fast and slow metabolizers, and the slow metabolizers respond to a lower dose and may have more side effects. But in the study that we've done, it didn't make a difference after 4 weeks. You get to the right dose and you respond. Some people have unusual responses or unusual side effects or different unusual doses, and we're interested in studying them. But the commercial genetic profiles that are available, they haven't really demonstrated that they're efficacious in choosing between different medications. This is for ADHD. It's different, I think, for depression. It's different for other disorders or illnesses. Yeah, so right now we don't have evidence for that. And the American Academy of Child and Adolescent Psychiatry has a pretty clear position statement on that as well.
Okay. Well, thank you so much. We are right at time. Thank you so much for sharing your expertise and all of your studies. Everyone, Stephanie put a link in the chat for you to access the slides, and that includes Dr. Stein's studies as well as his contact information as well.
Great. Thanks
and
again.
we will see you next month. Thank you so much.
Bye-bye.
Have a good rest of your week.